This is J. Llagas Maestrado, Clinical Resource Nurse of Adult Intensive Care Services. I'll be discussing to you today about shock. Shock is defined as a syndrome characterized by inadequate tissue perfusion that results in cellular, metabolic, and hemodynamic derangement. It is caused by ineffective cardiac function, inadequate blood flow, and inadequate vascular tone. Generally speaking, shock is the activation of multiple compensatory mechanisms that involves different systems in the body. In the cell, due to the inadequate supply and demand of oxygen and nutrients in the body, it causes inadequate oxygenation in the cell, leading to deficient energy production, which further leads to accumulation of lactic acid and fall in pH. This is your anaerobic metabolism. Furthermore, this will lead to metabolic acidosis that causes vasoconstriction, failure of precapillary sphincters, and peripheral pooling of blood. As a result, this will lead to the dysfunction of the cell membrane and failure of the sodium pump. It releases the intercellular lysosomes and digestive enzymes, causing entry of toxic substance in the circulation, which further damage the capillary endothelium, leading to the destruction, dysfunction, and cell death. Let's go now to the classification of shock. We have compensated, which occurs in the early stage of shock, wherein the body is able to compensate for the perfusion in the body, and manifestation might include tachycardia and tachypnea to maintain blood pressure. While the second classification is decompensated, which occurs in the late part of shock. Let's discuss about the different types of shock. 1. We have hypovolemic shock. 2. Cardiogenic shock. 3. Obstructive shock. And 4. Distributive shock. For hypovolemic and cardiogenic shock, the problem would be on the low blood flow, while obstructive and distributive shock is on maldistribution of blood flow. Let's discuss about hypovolemic shock. This is caused by the inadequate intravascular volume, which can be observed in hemorrhage, burns, GI losses, fluid shifts, fistula drainage, diabetes insipidus, hyperglycemia, and diuresis. For cardiogenic shock, this is due to the inadequacy of myocardial contractility, which can be seen in myocardial infarction, serious cardiac dysrhythmias, myocardial depression, mechanical restriction of cardiac function, and venous obstruction. For the third type of shock, this is caused by obstruction of blood flow, and this is termed as obstructive shock. This can be caused by tension pneumothorax, cardiac or pericardial tamponade, massive pulmonary thromboembolism, aortic dissection, pulmonary or systemic hypertension, congenital or acquired outflow obstruction, and vena cava syndrome. The last type of shock is the distributive shock, which is caused by inadequate vascular tone and is subdivided into 3. 1 is the anaphylactic, 2 septic, and 3 neurogenic. What are the complications of shock? It has 2. 1 is the systemic inflammatory response syndrome or SIRS, and multi-organ dysfunction syndrome or MODS. The primary focus of assessment is airway, breathing, and circulation. Diagnostic studies include thorough history and physical examination. Although there had been no single study to determine diagnosis of shock, it is imperative to conduct blood study, which might be focused on monitoring on the elevation of lactate and base deficit to identify acidosis, and then 12-lead ECG chest x-ray, and hemodynamics monitoring. Collaborative care includes identification of patient at risk for shock, integration of patient history, physical examination, and clinical findings to establish a diagnosis. It includes as well interventions to control or eliminate the cause of the decreased perfusion, protection of target and distal organ from dysfunction, and provision of multi-system supportive care. Specifically, in the airway, it is important that we maintain a patent airway and to maximize the delivery of oxygen through oxygen support or adjuncts. In order to maintain the circulating volume, it is important to administer isotonic solutions or blood products for the volume expansion, as this is the cornerstone therapy management for hypovolemic shock, anaphylactic, and septic shock. CBP monitoring is as well important. For decreased tissue perfusion correction, it is important to maintain a MAP greater than 60 to 65 mmHg, and it can be achieved by starting vasopressor or vasodilator therapy. For nutrition, you can start enteral or parenteral nutrition, and it is imperative to monitor protein nitrogen balance, BUN, glucose, and electrolytes. Specific management for each type of shock. For hypovolemic shock includes control and identification of the loss, and then restoration of circulating volume. For cardiogenic shock, it is important to restore blood flow, thrombolytic therapy, angioplasty with stenting, emergency revascularization, and valve replacement. They can as well put a patient on continuous hemodynamic monitoring, drug therapy, and circulatory assistive devices. Let's go to the septic shock management. It includes fluid replacement, hemodynamic monitoring, vasopressor drug therapy, and IV corticosteroid administration as ordered. Septic shock management includes as well antibiotics after obtaining cultures, glucose control, stress ulcer prophylaxis, and venous thromboembolism prophylaxis. It is also important to give epinephrine or diphenhydramine for anaphylactic shock, as well as ensuring maintenance of airway patency through bronchodilators or invasive endotracheal tube intubation. Fluid administration must be started, and then administration of IV corticosteroids. For the neurogenic shock, it is important to focus on the spinal stability by treating hypotension and bradycardia and monitoring for hypothermia. Let's go now to the nursing assessment. The focus would be on tissue perfusion, to which it is important to monitor vital signs, peripheral pulses, level of consciousness, capillary refill, skin, and urine output. You need as well to obtain brief history, pre-hospital care, allergies, and vaccination. For the plan, you need to set goals for the patient, and it includes assurance of adequate tissue perfusion, restoration of normal or baseline BP, return or recovery of organ function, and then avoidance of complications from prolonged states of hypoperfusion. Nursing implementation includes monitoring of the patient's ongoing physical and emotional status, evaluation of the patient's response to therapy, provision of emotional support to the patient and family, and collaboration with other members of the healthcare team. For neurologic status, it is important for the nurse to continuously orient patient and monitor level of consciousness, monitor cardiac status through continuous ECG, vital signs, capillary refill, and hemodynamics parameters, as well as monitoring normal and abnormal heart sounds. For the respiratory status, it is important to note respiratory rate and rhythm, breath sounds, continuous pulse oximetry, arterial blood gas, and to anticipate for intubation and mechanical ventilation. It is also important to know and monitor urine output or the fluid balance, skin for temperature, change in color, and then perfusion as well, like diaphoresis and assessment of bowel sounds. Nasogastric drainage might be ordered, and then stool for occult blood can be tested, INO and fluid and electrolyte balance, as well as oral care and hygiene, and of course, passive active range of motion. To assess level of anxiety and fear of the patient, it is also important to give PRN medications, therapeutic communication to the patient, referral to clergy or to social worker, family involvement, comfort measures, privacy, and call light within reach. For the evaluation, it is important to check if the patient had achieved the normal or baseline status, check ECG, BP, CBP, and PAWP. Check as well for normal temperature, for skin characteristic, urine output, normal RR and oxygen saturation, and then patient must be able to verbalize fear and anxiety. These are my references. Thank you.